this is such a long time coming, and you see a timeline behind me, but I wanted to say with regard to the last slide, that one of the examples about sort of impacting the environment and that you were sort of challenging us with in the last segment is that a number of us were from HIP-Cuyahoga, different people representing different parts of HIP-Cuyahoga were asked to work with HPIO on the State Equity Advisory Group so that we could craft a statewide definition that multiple sectors would use. And so that's an example of where we were sort of doing this work very locally, and we weren't necessarily seeking out, trying to be influential, but having been invited to be part of a number of 50 or 60 other people crafting this equity definition. That's the definition that ultimately, after a series of facilitated events earlier this year, is being used across the state. And so that's just an example, I think, of how you were challenging us earlier, and I got to thinking, wow, actually we are doing some of that, and maybe if we are able to do more of that, we can really push this even further. So thank you for helping us see that. So I'm just going to talk a little bit about the process that got us here. You can see the theme today for me is the historical context, so I'm going to continue on with that. So in the pre-2018 assessment, which you're going to hear about, which we're releasing today, we had separate assessments. As you know, our tax-exempt hospitals have IRS requirements every 3 years to do an assessment, and our local health departments had requirements every 5 years in order to achieve their public health accreditation. So those two things were sort of being done in isolation, although you heard Greg talk about earlier, our 3 local health departments came together for our 2013 assessment. So out of that, we came to this priority area of clinical care and public health working together. And we came up with 2 objectives. This was 5 years ago. The 2 objectives were, one, to create an infrastructure for shared assessment and community health improvement planning. And the other was to do a demonstration project where public health, not-for-profit, and health systems were working together around a particular chronic disease, and we chose asthma. So this is actually the realization of that first objective that we came up with out of our original Community Health Improvement Plan in 2013. And it's been a long time coming, and you're going to hear a lot about the different steps, but many of you in this room have been instrumental in making this happen. So we're moving from this working in isolation prior to 2018 to looking at 2018 this year as a bridge to a much bigger assessment in 2019. And the reason for that was basically logistical, and as Danielle brought up earlier, compliance, right? We cannot not look at that. So our 2 health departments, Cleveland and Cuyahoga County, had to do another assessment in 2018 for their accreditation, because again, it was 5 years ago in 2013. And university hospitals also had to do one on a 3-year cycle from 2015 to 2018. So we all came together to do this assessment in 2018. Chris called it assessment light, but it ends up being not really that light, because this is the actual document being released today. You can see the thickness of it is not a light document. But what it does represent is how we can work together for next year when we have more hospital systems involved. And so you're going to hear about that a little bit more later on. So you can see on your far right the groups that are participating in 2019. So I alluded to this in my earlier comments today, but one of the things that has been an outcome that we've been going for a long time is improved population health. Now, that means a lot of different things to different people. If you have one kind of lens, population health means something to you. In public health, it may mean something different than it does to physicians, or different to hospital administrators, or different than payers, right? But in general, there's this feeling that population health is something we should all strive for. And we try to come up with a unified definition of that. And actually, HPIO in Ohio has been really instrumental in coming up with not only a shared definition of equity, but also around population health, which has been very helpful. So in that vein, we wanted to give you an example of a state where shared, collaborative community health assessments, community health needs assessments for hospitals, community health assessments for public health departments, and resulting plans working together on what those priorities that are identified are, is actually improved population health. So you can see that New York has dramatically improved as far as their ranking with regard to overall health status when you look at the country. So this has been, we all got to be part of a webinar that they gave, and then we wanted more information, and so we've been in dialogue back and forth with them, learning about what they're doing. There are other bright spots too, but this is one that we found would probably be helpful to illustrate for this group. So we also know that we have a lot of challenges here. So this comes from the State Health Improvement Plan. We know that we have a lot of issues when it comes to our overall health status. If you look at the county health rankings that were referenced earlier, they have a lot of utility in understanding what factors are contributing in different states, in different locations, in different contexts. It's not the whole picture, right? But we know that we have some work to do. We have a lot of work to do. So this gives you the percent of individuals living in poverty in Ohio, and this is going to link to some outcomes or some priority areas for 2018, understanding that poverty is a major driver of inequitable health outcomes, and particularly in this community linked to structural racism. So, aligning the efforts. Well, we're all aware of the State Health Improvement Plan. I think many of you have been involved probably in the meetings, maybe even writing some of the State Health Improvement Plan, or at least contributing substantially. So we have the State Health Assessment and State Health Improvement Plan. State health departments are also going through the accreditation process, so that is also a requirement for them. But it's also the thing that they're trying to do nationally to make sure that we're all actually surveying what needs are important in each state and then also in each local context. So I described earlier how the health departments have their community health assessment and the community health improvement plan. So we say CHA-CHIP. And then the hospitals have a community health needs assessment and an implementation strategy, CHINA and implementation strategy. So essentially we're trying to bring these two together. It's an alphabet soup of acronyms, but you would not actually understand that this is a really big deal. For us to be able to have this document and meet requirements for both groups and actually have shared language is a huge milestone. And we've even been working through this, just even making sure that the attorneys looking at compliance and accreditation are all okay with it. It's been a real challenge.
Thanks, Heidi. So we're very excited to be here today talking to you all about this. I can remember last year talking about how excited we were just to be beginning the process, and here we are. We actually have the final report. It's available on multiple websites. And as you've heard this morning, this was really a growing movement to develop these coordinated health assessments that began well before I got involved in this process about 4 years ago. So this is work that HIP-Cuyahoga was instrumental in having the vision to achieve, and we're very excited that this priority subcommittee that's been focused on linking healthcare and public health systems has been successful in creating the first joint community health assessment for Cuyahoga County. So very excited about that. And then also, as Heidi alluded to, that the work at the state level really helped to propel this work forward, because when I sat down, when I was, I think, right fresh into my role working on community outreach for the Center for Health Affairs, sat down with Terry, sat down with Heidi, sat down with Dr. Kurt Stange, and they brought this idea of doing these collaborative health assessments 4 years ago. It was really hard to figure out how we might be able to do that because the timelines were not aligned. The health departments were on the 5-year cycle, hospitals were on a 3-year time cycle. One of our hospitals had reported early, the rest of the hospitals were on a different time cycle. So the work at the state level also really helped to propel this forward by requiring all of the health departments to move to a 3-year time frame. But I don't want to forget the fact that HIP-Cuyahoga really had this vision that predates so many of the folks even in this room. To be able to actually implement it and do it, you have to have willing partners at the table. So we definitely had very willing partners in the Cleveland Department of Public Health, the Cuyahoga County Board of Health, and then university hospitals. And the change that Danielle has been able to achieve at university hospitals is really admirable, because getting those big systems to make these shifts is a huge amount of work. I really cannot overemphasize that enough. All of the different people that she had to convince that this was the right way to move and advantageous to the health system, that took a huge amount of effort. So kudos to them for being willing to take that on, and then obviously the other partners, Case Western School of Medicine, HIP-Cuyahoga, and the Center for Health Affairs. And so we've been doing this, as we've been joking, this 2018 CHNA Light, which is obviously not light with a 300-page document, but doing that on the heels of the 2019 assessment that's going to bring in even more partners. So we're very excited that additional hospitals are going to be able to join those that define their service areas to be the same. So we'll have Metro Health, which is incredibly exciting. Metro doesn't even they're not even required to do a health assessment, but they're so committed to community health that they're at the table and they're going to be partnering with us on this. We also will have St. Vincent Charity Medical Center, which we're incredibly excited about, all the good work that they do, and then Southwest General Health System. And then we also have had Cleveland Clinic has been at the table participating in all of the conversations as well. They define their service area slightly differently, which precludes them from being able to do a joint health assessment. But we're very excited that they're also going to be part of this process, which will also help us continue to achieve alignment with the SHA and the SHIP in Cuyahoga County. So we wanted to spend a minute to walk you through the process that we used to develop the 2018 assessment, as I think a theme that we've been talking about all throughout this morning has been the importance of building trust. Cannot overemphasize that enough. This is, you know, these assessments are required for accreditation purposes on the health department side. There are IRS requirements on the hospital side, so you have to have people who are comfortable with what people's intentions are when you're creating these. So that has been something that we have spent a lot of time building and we will continue to build. Also understanding what the shared needs and resources are. We continue to learn more about that. Me and my role serving as on the hospital association side, I have a very solid understanding of the IRS requirements, but I'm still learning about what the FAB accreditation requirements are, so there's a lot of shared learning that we're still doing. So we spent a lot of time about a year ago actually developing what the finalized table of contents would look like, and then we really drove the process based on that table of contents and developed a timeline. The timeline was incredibly aggressive. I cannot overemphasize that enough. There were times when I was nervous we weren't even going to have a report. There was so much data analysis that had to be done, and so much writing, and then so many layers of approval we had to go through. So we spent a lot of time analyzing data. We worked with a consultant, Cypress Research Group, and then the epidemiologists at the County Board of Health spent a huge amount of time analyzing data, and we were very fortunate to have residents from Case Western Reserve University School of Medicine who were able to help us with that. And then we also gathered qualitative data, so I did a few interviews with folks in the community, key stakeholder interviews, and then Terry had a really great idea that we should leverage all of the great existing community voice data that other entities had gathered. So we took advantage of that and worked with entities like IdeaStream that had gathered information, and United Way, and a host of others who had already gathered a lot of community voice data that could inform this process. And then we worked through the writing, editing, reviewing, the prioritization process, and then we had, again, all of the approvals and then posting and marketing, which begins today. We just launched on a lot of platforms a social marketing campaign or social media campaign, and then we also have a traditional media strategy.
Can you turn the mic up at all?
Oh, sure. How do I turn it up?
It's on. Maybe just hold it.
Okay, let me hold. Is that a little better? Okay, good. So some of the key findings we had from the 2018 assessment, and there's a huge amount of data. I really encourage everybody to take a look at it when you have a chance. But some of the key findings we had is that our strongest indicator of health status is poverty. That probably is not going to come as a surprise to most people in this room based on the work that you all do. We also have some other statistics that are interesting that we wanted to highlight. Cuyahoga County residents are 118% more likely to die from homicides than Ohioans overall. We all know that the opioid epidemic has been wreaking havoc all across the country. Here in Cuyahoga County and the city of Cleveland, the rate of unintentional opioid deaths for Cleveland is 5 times the US rate. And then we know we have some incredibly concerning racial disparities. Black non-Hispanic babies are 3 times more likely to die than white non-Hispanic babies, so we know infant mortality continues to be an issue that we need to have focused attention on. And then we have higher rates of childhood asthma among Black and Hispanic children in the county compared to white children. So we mentioned that there's this huge amount of data, and we spent time prioritizing what the greatest health needs would be for the 1-year implementation plan that we are beginning to work on. And we looked at the magnitude of all of the health problems, we looked at the severity of the health problems, and then we looked at the magnitude of the health disparity when we were coming up with these prioritized health needs. So this list, it's numbered, so it's in no particular order, but these are the 5 prioritized health needs that are going to guide the 1-year implementation plan that we're going to be developing. And again, we're going to roll back into the 2019 assessment. We're going to be working on that sort of simultaneous to this 1-year implementation plan. And the 2019 assessment is going to pull in more partners. So as excited as all of us are about this 2018 assessment and all of the work that went into it, we wanted to be open and honest that, you know, there have been hiccups along the way. We've learned a lot. We've had a lot of lessons learned, and it's actually going to be very helpful for the 2019 process. So I like this quote: any change, even a change for the better, is always accompanied by drawbacks and discomfort. So there are things that we know we want to do better. We know that we want to have greater community engagement in our process for 2019. The timeline was so incredibly aggressive for 2018 that we couldn't really roll this out in exactly the way that we wanted to, but we're excited to strengthen our efforts for the 2019. So we are moving into the planning for the 2019. We're still developing what that plan's going to look like. We have new stakeholders coming to the table, and we think that will continue to grow. So Greg in a minute is going to highlight more information about equity, diversity, and racial inclusion and how that continues to be a key focus for all of this work. We're going to continue to build trust with all of the stakeholders and the new stakeholders that will be coming to the table. We want to continue developing shared understanding of needs and compliance requirements and how we're going to align with what's happening at the state level. The state's actually going to be beginning their new process to develop a new state health assessment, so we want to be aligning with that. But we know we're going to be doing a lot of data analysis. We're really excited. We're going to be launching surveys in the first quarter of 2019. We're going to be doing a mailed survey of adults and also a mailed survey that will go to parents of children 0 to 11. So that's going to give us a ton of new information about the health needs in our community. And we're going to be very conscious to make sure we're oversampling African Americans and Latinos. And then we'll continue to analyze publicly available data sources. We are very fortunate in Cuyahoga County. We have a ton of publicly available data, so we're going to continue to leverage all of the data that already exists and incorporate that into the 2019 assessment. And then we'll also be doing some key informant interviews. So that's the process as we know it. It's still developing. And I'm going to turn it over to Greg for a minute.
Can we pose a question?
Sure.
So can you speak more to, you mentioned the Cleveland Clinic is not a part of the combined health assessment. At this point, can you speak more to that? What the reasons are?
Sure. So the way the IRS requirements are written, you have to have the same definition of service area in order to create a joint assessment. So Cleveland Clinic, based on where all of their hospitals are located, they use a zip code definition of service area, which many hospitals, it's actually relatively common. Many hospitals use a zip code definition of service area. So they continue to do that. And they've actually, because they have, I think, 24 reports that they need to create, they've already started and they're almost wrapping up a lot of their health assessments for many of their facilities. So they're doing it on a facility by facility basis. UH for this round of health assessments switched from doing a zip code definition of service area to doing the county definition for 8 of their facilities. And then they're doing county definitions for their other facilities outside of Cuyahoga County. So it's all based on how hospitals define their service area, and they have quite a bit of leeway based on IRS requirements of how they define that. Did that answer your question?
Yeah, it just seems like the Cleveland Clinic is like a central player to everything in Cuyahoga County and not have them at the table in the same way as the other large hospital systems. It's like elephant in the room.
They have been.
So they have been, yeah. I mean, fortunately, the folks at Cleveland Clinic have been at the table throughout even the 2018 assessment process, and they used some of the data for one of their health assessments that needed to be finished in 2018. And they've also been continuing to be at the table in 2019. So they're at the table and they're kind of, helping to inform the process. And so they're continuing to stay engaged. So they have been engaged, and continue to be engaged. And I think they're looking towards the future to see, how we can continue to strengthen our relationships.
I was just going to add that we're aggressively trying to do this now, but we don't actually have to be aligned quite yet. And so I think all of us are looking to the next 3-year cycle as the point at which it's even more of a smooth process. And so at this point, with our Cleveland Clinic colleagues, some of whom are here, but not all of them, they have been actually helping us see where the points of intersection are and actually where we can use data together, and also where we can use interviews and how we can find the places where we can be mutually beneficial, and thinking about in 3 years where are we going to be. So I totally see where you're coming from, the questions you asked, and they're really good. But I want to like fairly represent that this has been really a labor on everyone's part, and I think everyone has come to the table with the intention of making sure that the community's voices heard about what the most pressing issues are, and also that we eventually come together with resources to collaboratively address those issues. That's not where we're at right now, right? We're talking about an assessment. We're not yet talking about bringing our resources together to address those issues. So we're just in our infancy in this process, but I want to make sure we give everyone credit for coming to the table and really trying to build a culture where we can actually do that, even though it's 3 years out for the next round, we're really working toward that. That's, I think, all of our best intention to get there.
Thank you. I just want to say, as we transition through this last part, that both Kirstin and Heidi have really been beacons of light on this process and have worked diligently in front and behind the scenes. And there are also critical actors sitting in this room who have gone beyond a reasonable amount of work within their institutions to try to make this happen and to see it culminate in us being able to do something different than we've ever done before in 2019 is a stake in the ground for us to move forward from. So though we would like to have everybody sitting at the table singing Kumbaya, unfortunately, that's just not the way the dynamics work this time because of some logistical things we have to work out. But people are engaged. Nobody's walked away from the table, and we think that's a big deal. But last but not least is that's the dynamics of this kind of work. And what we always have to understand is people are always motivated by their organizational interests. They have to be. So when they come to the table, we have to think about those interests in the context of the work we're trying to do and build those systems and structures that allow for that to happen. So I'd just like to say thank you to all of you guys, because this would not be happening. 2019 wouldn't be a hallmark for us on this work, and maybe our document won't be 300 pages, it'll be 1,000 pages. What do you think? Okay, the only other thing I'd like to say in brief is that, once again, one of the things that we really did articulate as a value proposition moving into this 2019 assessment process was that we were going to try to make sure that we did this process with a view through a lens of equity in terms of not only the processes that we use and the oversampling that we do, but also in terms of how we design questions and who do we go out to question. So those kinds of things become concretely different from the way we've done it in the past. The other thing we want to do is when we get those reports back and look at the data that comes from the oversampling, we want to rethink what that data really says, as opposed to it just being data points or giving us the same information that we know that exists. How we think about the data will lead us to do things differently in the future. Once again, using an equity lens. So it's not just the data itself. It's how we think about the data, how we use the data, and then how that data becomes the floor or the foundation for us to use equity in a context that's different than we have done it before. Okay? So we want to thank you all. Hopefully you have lots of questions about this as we move forward.